Happy New Year, y'all. We're getting Serena. Happy New Year, Serena.
Hey.
So, first of all, I'm so excited that you got a dose of the vaccine. So I wanted to kind of bring that up first.
Yeah.
You got your first dose, and I'm so happy that you got your first dose already.
I'm so excited I got my first dose. I was very, very lucky. I wasn't actually, because I'm not, like, working in the unit or anything like that. But
Okay.
I was helping out with the hospital team to vaccinate, you know, all the highest risk people. And they actually had a few people that didn't show up the first day. So then they offered the vaccine to some of the volunteers. And I was, of course, like, yes, I'll take it right away.
Yes,
So
awesome.
I was very excited about that.
And then in 3 weeks, you get the second one?
Yeah, I'm getting the second shot next Monday.
Okay.
So theoretically, now I'm 2 weeks out from the first shot, and I should theoretically have some antibodies, but the second shot gets you more protection.
Yeah,
so
and all that T cell production too. So you might have some of the symptoms from the second shot, because it sounds like everybody tolerates that first shot pretty well.
Yes, and I've done several sessions of just helping out the vaccine teams, like at the hospital and at the Department of Health Essex County sites. And that's been really, really interesting because you get to meet a lot of people from the community, and it's just very interesting to see the logistics of how to roll out the vaccine. And it's definitely challenging. I think everybody's going to, people are worried that we haven't given a lot of shots yet, but I think they're going to continue to ramp up because we're learning as we go, and we're learning a lot. And, we're going to get better.
Of course we are. We've already got some great questions coming in. I just want to say hi to some folks. Michelle, Baby Bell, Hinal, Spinning Glory, Court, 5, KBM, Patricia. It's so great to see you all. Masa, Melissa, Fiona. We do have some good questions coming in. So this first one that I want to bring up, we see this a lot on the Fertility Answers app, is myth questions about foods and so forth that haven't really been studied, but that, get passed around on social media sites. So Danny Marie asking, does eating pineapple, Brazilian nuts, and McDonald's French fries help an embryo stick after a transfer?
There are no randomized placebo-controlled multi-center trials in a peer-reviewed journal on that I am aware of. So I think all of those things have their pros and cons, and I think
McDonald's fries has pros and cons.
Yes.
What pro?
McDonald's fries, when you're feeling blue, can actually
stimulate endorphins.
Little smile on your face.
Okay, that's true.
Okay.
So that's a pro. That is a pro.
I would definitely just a couple fries, and we'd like to avoid ketchup because there's a lot of like yucky things in ketchup too. But like every once in a while, you treat yourself to a little tiny bit of something that's quote unquote bad. It's not going to kill you, and sometimes you need a little little bit of that. Now, in general, though, we want, whole foods. We want non-processed foods. We want lots and lots of plants. We want, a healthy balance. Brazil nuts are supposed to be good because they have, like, selenium in them and healthy fats and a lot of protein. But, like, what if, a lot of nuts have a lot of extra salt added, so you do have to look at your label.
Right.
And if you eat, like, a gazillion Brazil nuts, that's really not a balanced diet.
Yeah.
And same thing for pineapples. Pineapples have fiber, they have vitamins, they're yummy, they can be nutritious, but eating a ton of pineapple is probably too much carbs and sugar.
Yeah, exactly. So it's all the balance, and I think that the real key too, Danny Marie, in terms of what helps an embryo stick, is that we don't have a lot of good science on that either.
We think a lot of it is mostly the embryo, so it's less about being sticky and more about you being as healthy as you can be and trying to get the best embryo in there, and if that one didn't work, to keep on going.
Right, and we did a session where we talked about embryo glue, right? And could you just sort of really quickly summarize, the studies that we do have.
There's a little bit of data that embryo glue might be helpful and offer like a little bit of an advantage. It's still kind of controversial because the studies are mixed. So it's certainly not a standard thing. It's kind of in that category where, a lot of people are charging for embryo glue. And while there's some data that shows that it might be positive, it's certainly not a standard in the industry. So, we don't use it at IRMS because we really haven't felt that that it's been consistently beneficial in the studies. So it's an interesting thing that, I think we have to keep our eye on, but I still feel like the vast majority of the data shows that if we have a good embryo, it's going to stick.
Right. Okay. Love that response. Caitlin, good to see you. Great question. Is PCOS hereditary?
Yes, there's definitely a lot of evidence that PCOS can be hereditary. There's some people also that feel that there are environmental influences as well as epigenetic influences. It's complicated. It's definitely not one single gene. There seem to be multiple genes, and PCOS may be a whole group of diseases that somehow interrupt the very complex pathway that causes regular ovulation. And once you interrupt regular ovulation in somebody who has healthy ovaries, everybody looks a little PCOS. So PCOS might be like the common endpoint for anybody that gets their ovulation interrupted by whatever factor, whether, like you're, taking hormones or you have this imbalance of your hormones because of your genetics. But we do think if your sister has PCOS, the risk that you have PCOS significantly increased, definitely.
Right. We do have a genetic kit for consumers at fertilitygenetics.co if you want to take a look just at the website itself. We do cover the PCOS genetic variants, and there's either 11 or 14. I'm blanking on the total number. But we do, I think, a decent job of kind of explaining, and that it's helpful knowing if you are more genetically predisposed rather than knowing if it was lifestyle driven. Because even if you are genetically predisposed, even if you do have hereditary risk factors, we always advocate that you can reduce your symptoms because 70% is the environment regardless of what your genetics say.
Absolutely.
Right? So 30% genetics, but 70% is what you put in your mouth, if you eat, how much exercise you do, where you live, like what, how you
sleep. Good sleep is so important to insulin resistance.
Yeah, all those things. And so we think that it gives you some autonomy to know if yours is more genetically predisposed and just kind of empower you to make those positive lifestyle choices. So if you do decide to pick up a kit, it is a pretty actionable report, and you can speak to a genetic counselor too once you get it, so if that's helpful. Hinal, hi Hinal, great question here. How long does it take to get pregnant?
So theoretically, for people under 35, unprotected intercourse for a year, 85% of people should be pregnant at the end of that year. We say 6 months for people who are over 35 because we start worrying about your fertility declining more quickly as you get older, because that's just the biological clock for females. So do you think that answers the question?
I think it's a great question. I think, Hinal, the thing is that if you're asking the question, you probably have been at this for a while, and you probably found us because you're concerned that you might be struggling with infertility. So, the sort of reverse way of what Serena said is if you're under the age of 35 and you've already been at it for a year, it's time to get in touch with a fertility specialist to do some diagnostics. If you're over the age of 35.
I think you brought up a really good point, because I think people can get confused about how they count how long they've been trying. And really, we don't expect you to try. We're just saying if you're not using protection, like a condom every single time, or you're on birth control pills, you never miss a pill, or you have an IUD, you don't have really reliable contraception, then to me, you're trying because you're exposed to possible pregnancy. So I see that a lot of patients tend to, maybe because like you don't want to be labeled infertile, and we don't want to put labels on you either. But I think Alice is totally right. If the question is coming up in your mind and you're here, probably means, you just need more information. And it doesn't matter if you've been trying 0 months or like 100 months. If you need information, you should see, you should check out MedAnswers, consider seeing a specialist, and just get some good advice, get an evaluation.
Yeah, we advocate that, we are advocates for you, so, what we support you doing is asking the right questions first of your OBGYN, but the OBGYN tool set is different than a fertility specialist tool set. And a lot of people aren't getting into a fertility specialist because they're afraid they're going to be sold IVF. We help you down that path so that you're not sold IVF. But what we do advocate for is that they have wonderful diagnostics at their disposal. They just have more tools in their toolkit because they did 2 extra years of fellowship to be specially trained in dealing with complex 3 years of extra training to make sure that they get you the answers that you need. And so we just say get to one of them as fast as possible so you get a proper, full, and complete workup. A lot of people come to us and they say, well, my OBGYN already looked at everything. But that's not true because they don't even have the tools to look at everything.
Exactly. So, and I think we all have to realize that the healthcare system is not ideal. And in a perfect world, you would get a lot of these evaluations before you even thought about conceiving.
Yes, we talk about that all the time. Serena and I are advocates for something we call the fertility wellness checkup. Before you even go in to try to conceive, let's look under the hood of the car, right? Like let's see what we're dealing with, and if there are any lifestyle recommendations that can be made, so that you create the healthiest environment for a healthy baby to grow. So we want healthy babies, healthy mamas, and healthy families.
Absolutely.
So hopefully that helps a little bit. Turkey is hi from California. Hi, I just left California, came up to Idaho. I'm in a lot of snow.
You still look like a California girl, though.
I know, I do. I know. It's the highlights and then like my purple peekaboo, which I will not get rid of. I won't get rid of. So I will keep the Californian in me. Otis in Chicago, what do you think about pregnancy and vaccine? She's not an essential worker, but I think that this is going to come up a lot. And so we have to keep this evolving.
Like to promote my own, Instagram site, because Dr. Serena H. Chen, because I have been really working hard to try to answer people's questions on the COVID-19 vaccine. It's been a real learning experience for me, and I have a few IGTV videos that I think will be helpful to you on there, and so I'm going to try to create more content. So right now, all the societies, ACIP, the Advisory Committee on Immunization Practices in the United States that advises the CDC and the FDA, ACOG, American College of OBGYN, ASRM, American Society for Reproductive Medicine, and SMFM, the Society for Maternal Fetal Medicine, all have statements out there. And maybe Alice, you can put links up there. There's a lot of words in there, but the bottom line is they feel like the mRNA vaccines, the Pfizer and the Moderna, should be reasonable, very reasonable to consider in all women who are trying to conceive and who are pregnant. And everybody should weigh the risks and the benefits.
Right.
So the flu vaccine, we're like across the board. We want everybody to get that. But obviously the COVID-19 vaccine we know a little bit less about. But for the great majority of people, the risks of the vaccine seem to be much less than the risks of COVID-19. We know COVID-19 can be really serious in people who are pregnant. Mm-hmm. If you're pregnant, even if you're healthy, those pregnant people seem to get much more serious cases of COVID-19 where you end up in the hospital, where you end up on a ventilator. And so the theoretic risks of the vaccine seem to be much lower. Now, you're right. It's an emergency use authorization. Hi, Dante.
He's so loud. No, we're on an Instagram Live, Dante. He's running over some paper. I tried to hang some wallpaper for our backdrop and it fell. Dante, it's too loud, love. In 20 minutes. Yes.
So we, it's, we don't have a big study in pregnant women or women trying to conceive, but we know a lot about the science of this vaccine. We know how it works. We know the physiology of the human body. So we can say, given all the science that we know about how the vaccine works, we just cannot really imagine that there are going to be serious issues in pregnant women compared to non-pregnant women. So given that we know COVID is so risky in pregnancy, and just even if you're not pregnant, COVID is very risky, we do feel like the vast majority of people who are trying to conceive and pregnant will, when they look at it with their doctor, they will find that it's probably better for them to get the vaccine than not to get the vaccine. Obviously, you have to feel comfortable. You should talk with your doctor about it because your doctor knows you the best. And obviously, I can't give you medical advice on here, but in general, that's kind of what we're thinking. And
what I love about all these statements is that it is an empowering statement where it says, discuss this with your doctor, because that's what we advocate for, is to have the benefit risk conversation with your doctor for you individually, so you can understand what the benefits and risks are, and you can make the decision, so there is no government body saying everyone should get it.
It's good to know the general information. Messenger RNA goes into your muscle here, and then you feel a little sore, and a lot of people feel a little fatigued. That's what we've seen mostly. Obviously, there can be other side effects, but the severe side effects do seem to be remaining small, and we have vaccinated millions of people in the United States. We're way behind the 20 million number, but 4 million people have been vaccinated. Okay,
awesome.
So that's a lot of people. And
that's a lot of data.
I thought it was very reassuring that the messenger RNA just goes to the cytoplasm. It does not enter the nucleus.
Right.
And then your cells just go, oh, messenger RNA, let's make a protein. And they make this little piece of spike protein. And then your cells go, here's the spike protein. And then your body goes, oh, that's not normal. Let's make antibodies and T cells.
And T cells. That's my favorite part is the T cells, because as a cancer survivor, you care a lot about T cell production.
Yeah.
Because that's so important. And so
Alice, they're thinking this messenger RNA thing might be able to also vaccinate against cancers. You could direct your body to make molecules that maybe would attack the cancer cells. I don't know a ton about it, but the technology is amazing.
I agree. The technology is really exciting.
It's so clever, and yet it's so simple. This vaccine it's really just messenger RNA, and then it's got a little lipid package that lets it pop into the cell, and so
very clever. And that's why, in part, why they were able to make it so fast, because the technology itself took a long time to develop, so that they could have very fast delivery systems for new viruses and things like this pandemic.
And those technologies like the nanoparticles, the lipid package, the manufacturing of messenger RNA, all of that they didn't start from zero.
No, that's not new. They did. They had the toolkit already. They just were able to use it very quickly for this. Now, so I think people get nervous about that. They get nervous about the fact that it's quick.
Our two newer vaccines, AstraZeneca and Johnson & Johnson, and, I'm not a vaccine expert, but knowing that those are live virus vaccines, they're not live coronavirus. They're a separate virus, an adenovirus that just does kind of the same thing. So it delivers a piece of DNA. The DNA goes into your cell, and it's used by the machinery in the nucleus to manufacture messenger RNA, and then from there it's like the Moderna and the Pfizer vaccine. So it's a couple steps before. But the fact that they use a live, attenuated, or weakened adenovirus to deliver this piece of DNA means that we're probably not going to recommend it in people trying to conceive or pregnant, because
Right.
The history has been, we don't do live virus vaccines in pregnant women or people trying to conceive. So like chickenpox and measles are two very common vaccines, or MMR vaccine, that are used all the time and gazillion for a really long time, very successful, very safe, but they are live virus vaccines. So we tell people, once you're done that vaccine, wait 30 days, and then it's okay to start your IVF or to start to get pregnant.
So Patricia's asking on the same topic a follow-up question, which is really important, which is, what about the vaccine for men? Because we were just approaching it from the standpoint of pregnant women.
So ASRM has come out and said they feel that everything they know about the vaccine, there is no reason to believe that anything in the vaccine physiology would impact fertility for men or for women. There was some fake news stories out there that went kind of viral, and it's not based on any real data, and it doesn't actually make sense in terms of the science. And if you go on ASRM, they do have a statement about the vaccine, and they do specifically address that particular point. And so even though we don't have long-term fertility data yet, because obviously this is an emergency use authorization, there is a lot of scientific reasons to believe that this will not have a detrimental effect on people's fertility. Now, having said that, a small number of people might get a high fever. If you get a high fever, theoretically, that can affect sperm and eggs and embryos. So we usually say drink a lot of water, keep your temperature down with something like Tylenol, but definitely call your doctor.
Yeah, absolutely. Okay, we have a big hello from Algeria. High five, TPMA from Algeria. Cool. That's so cool. All right, so we have a number of questions that came in. We'll try to keep these answers short because Serena only has 15 more minutes. Let's see. So we did that one. Will you know that you're having a miscarriage while on progesterone and oil and estrogen patches? Are miscarriages always obvious, I guess is the question, Serena?
Not always. Sometimes progesterone can delay bleeding a little bit, but, you know, a lot of people that are on progesterone and oil are being monitored pretty closely. So usually like weekly. So usually we find out very, very quickly what's going on.
Okay. All right. Haj asked, she had an FET. Today is day 9.
Congratulations.
But she's not feeling anything, so she's worried that it failed.
Oh, that's totally normal.
Yeah, totally normal. So
totally normal.
Not everybody feels anything at all.
Let's think positive. Okay?
Yeah, exactly.
Until we can't think positive.
Remember, there are lots of people out there in the world who don't know they're pregnant until like 12 weeks. We're so hyper-focused on our bodies when we do an FET.
Sometimes there are people who don't know they're
pregnant
going
to deliver. I know.
In labor.
I know, but we didn't used to believe that until they made a reality show out of that topic, because none of us would believe it.
I used to see that.
I'm sure you did.
You do OB/GYN residency, you see that all the time.
And you see it. Yeah. I know. We never, like, the public never believed it, so they had to make a reality show to make us believers out of us. But I know, I've seen it. But I think the thing is that we're so hyper-focused on our body when we're going in for an FET. We're looking at every sign and symptom. And for some women, there just are none. And it truly doesn't mean anything.
Some people are lucky.
Yeah, well, exactly. I am not one of those people because I definitely, I felt everything. I actually, my nausea starts way before pregnancy even shows up on a test stick. All right, getting back to some other, we have quite a few questions. One is great about PCOS, and it is, we need to address the over-the-counter test strips that only measure LH, because her question is,
at least half of patients with PCOS, or close to half, will have these elevated LH levels all the time, so it can make it really hard to monitor. And we have to remember that 20% of people with perfect cycles, we just can't pick it up on the LH kit. But, you know, this, there are some really cool things out there, like the UVA,
UVA.life. We love.
That's a really cool technology that does use a quantitative technology to measure your hormones in urine. So that can help combine LH plus progesterone, which is really what you need to confirm ovulation. So the LH kit works for some people, and if it works for you, that's great, except I always worry about people being obsessed about when they're ovulating, because I have this beef against that, because this is not how our system was designed. The human body was designed. The egg takes her time getting ready. And she's only fertilizable for 48 hours. And, you know, if the sperm is not there, is not hanging out waiting for her, then too bad for that sperm. So if you don't want to, if the sperm needs to be delivered at exactly the right moment, I'm not sure we want that sperm.
Right.
A healthy sperm is supposed to be able to hang out in the tube and be perfectly capable of fertilizing egg for days, okay?
Yeah.
So that's a good sperm. So, and there's, everybody, most everybody makes millions of sperm. So intercourse twice a week, you should be covered. That if you have intercourse twice a week, you always have some good sperm in your tubes. So whenever the egg comes out,
you're ready. Yeah, they're ready. The other thing to keep in mind, though, on that front, is it's so normal for people with PCOS. And you said this, and I want to underscore it. It's so normal for people with PCOS to not have confirmed ovulation if they're at home. And that's why we like the uva.life kit.
Yeah.
Because it does confirm if you've truly released an egg or not. And you can use a FertilityAnswers 10 discount code on there. I ordered mine. I'm 44 and I'm doing another frozen embryo transfer, but I wanted to know, I just wanted to see, do I still ovulate or not? I was curious. And so my kit came, but it came a couple days after I moved from the house. So my neighbor has my kit. So she's got to send me my kit up to Idaho. And, but I'll get my kit, but I'm really excited to try it. Also just because I'm fascinated with data, right? And the more I'm at this age where the more data that I have on my own body, the more autonomy I feel about choices that I make.
Gathering data is wonderful. I just don't want people to feel like they have to do it, like if it's becoming a chore. And then I worry about couples.
Sex becomes a chore when you're in our demographic. Sex is a chore to us. We want romance back in your life. Let's face it, if you're struggling with infertility, sex very much becomes a chore.
Right. And
we're trying to get our timing right, our eating right,
When you add all this timing stuff on top of it, it's hard. Whereas I feel like if you say, let's have 2 dates a week, that's much more doable. Even if you're tired. And, people who are super tired, if you have regular cycles, you could just have 2 dates your second week of your cycle.
I don't think we'll address it on this call, but we'll do another one all about sexuality, because the truth is not everybody likes sex enough to have it twice a week.
Yeah, so we have to work on that. That sounds like a good topic.
We should have a topic. We'll do a whole topic on that. Okay. All right, Caro, IVF cycle canceled due to an active cyst on ovary. That sucks. Sorry. Was on birth control 2 weeks prior. Is it likely this will happen again? What can be done to prevent it? And what if it's an issue that persists? It's pretty common.
So I would say let's try to do, if you can we try to do IVF without birth control pills? Because some people it just doesn't work.
Right.
You might just need to start your injections on day 2 of your cycle. Hopefully that's possible. The other thing to talk with your doctor about is something called luteal phase priming. So a lot of reproductive endocrinologists are using that, and that can often be very helpful to deal with something like that.
Yeah, great advice. Take that back to your doctor. A lot of us get started on birth control because clinics do batch cycles and they want to get us on their cycle. But there's other ways to get you on their cycle, and that's that luteal phase, right? When
the other thing is to think about, the other thing that can be considered is a random start and freezing all your embryos, and then you can put the embryos back when you're ready, because the whole thing about your menstrual cycle being off is it really only important if you're doing a fresh transfer. Yeah.
Okay. Really important to hear that too. Yeah. So let's see. Hey, Luciana, it's good to see you. Happy New Year to you. I'm due to start IVF tonight. Yay! Oh. She had 4 failed IUIs and a 2-month break. She hasn't bled in 15 months after being off the pill. And last night and this morning, she got a bleed. Her ultrasound confirmed no pregnancy. So she should be able. I do exist. I think I exist. Do I exist, everybody? The 7-year-old wants to know if I exist. She said, she wanted to know, is it, No, it hasn't, sweetheart. 12 more minutes, because I'm looking at the clock, I promise. Actually, 8 more minutes, sorry. Not 12, everybody, 8 more. He's a little bit frustrated because we just moved all the way to North Idaho, and so he's a little bit bored and getting into his new routines. She doesn't want to wait any longer, but she's wondering if she should wait another month to get a bleed again, or just start her stims tonight.
I think if your doctor feels comfortable starting you now, then I would go for it.
I would go for it too.
Yeah.
You've already struggled so much, Luciana, that I just wouldn't encourage another delay, because you already did so many IUIs. You already took a break. It's such a great sign, though, that you started to bleed, because I feel like if you go ahead and proceed with IVF, you should expect a good result with your lining.
Yeah, and if you got an ultrasound and blood work, then that means your doctor and your nurse are comfortable. But, you could, I would start, but follow up with them, because maybe they want to, if there's any concern about the lining development during the cycle, they could always think about freezing, so there's a lot of options, but and
it's also really good. I mean, you should feel like proud of your body, like celebrate your body, like shedding anything, right? Because it's doing its job. You're getting a nice cleanse.
Good luck with everything. Yeah.
Yeah. So exciting.
Egg juju.
Completely. Hilo Scooby, really important question. 48, how long would it take to get pregnant? I mean,
48 can be really hard. I would say that, certainly reasonable to try a little bit, but I'd say because the vast majority of people actually completely lose their ability to have a healthy pregnancy by, maybe by 45, or 44 or 43, honestly. And, that I would go see a doctor like now and get evaluated.
Yeah.
Even
right
with
away.
donor egg, which is the donor egg usually becomes standard around 43, 44, 45 and above, because we can't get healthy eggs in most people. It's a good idea to talk to a doctor and to see what your options are, because, we try not to do transfers over 50, because a lot of people are moving that because that's the natural age of menopause. But, so a lot of practices go to 55, but at 48, you're even starting to get closer to the limits of the donor egg programs. So that's definitely something, and your risks of pregnancy just because of your age are higher. So it's definitely a good idea to get some really expert advice on that.
And if you want our help, we have fertility advocates, fertility coaches, all for free for you. So please just drop us a DM and I'll put you in touch with somebody to talk to.
Yeah, because you don't want to fool around. You want to go to a really good person.
Let's beeline you to a great person. Mirel, I think Mirel, just got diagnosed with a polyp in her uterus. She is doing 2 months of Lupron and then lap surgery before an FET. Will the polyp regrow, and will that be an ongoing issue? And is there a way to prevent it in the future with diet?
Polyps can sometimes regrow. The most common thing we see with polyps is that people with irregular cycles tend to produce more polyps. So it's very important to regulate the cycles. Like once you have the baby, if you have irregular cycles, maybe you should be on the birth control pill or progesterone-releasing IUD or something like that. Polyps are usually not associated with an increased risk of cancer. They definitely can regrow, but a lot of times after pregnancy, people don't have issues. The big thing is the regulation of the cycles. So.
Right. Great advice. Okay, and we have time for just a couple more questions. Amy Payton, under 35, it took her 2 years to get pregnant the first time. Will it be easier to get pregnant a second time?
Well, a lot of times already having a first pregnancy definitely puts you in a very good prognosis category for the second pregnancy, but everybody is older for their second pregnancy than they are for their first pregnancy, and age can be a powerful and very common cause for difficulty conceiving. So I think, talk to your doctor, get a checkup, make sure everything's, looking good.
Yeah, and if there was no clear-cut reason that it took 2 years to conceive, right? I mean, if you went down that path and it just took that long out of randomness, and there's not a specific reason that it took that long, right?
Yeah, I feel like for the second child, because you're already older, I don't think I would wait like 2 years. I would just get an evaluation now.
Don't wait.
And then if you don't get pregnant in 6 to 12 months, depending on whether you're over 35 or under 35, I would definitely consider treatment.
Yeah, but I could totally concur with don't wait. We tell everybody don't wait. Even if knowing that it took you 2 years, I would go ahead and get checked out now, just to see if there's anything that might cause a delay.
Really common things like your thyroid. A lot of people, as they get older, their thyroid goes out of whack.
That's
and
right.
They do not have any symptoms, and that can be a huge factor that's super easily corrected for pregnancy.
Yeah, exactly. All right, and Jess Carney, after 3 cycles of failed IVF, their clinic has offered a drug cycle rather than a natural with added progesterone after transfer. Is there one that you would recommend? So wouldn't all the IVF cycles been included drugs? Are they thinking failed IVF and they're going to go down to clomid? Usually like go from clomid then go up, right?
Yeah, I don't understand the question.
I'm a little concerned. Yeah, I don't understand the question completely. Just maybe DM us a little bit more specificity, and then I'll work with Serena on getting you a good answer for that. So Haj, we answered that question about not feeling anything, so normal, just natural versus medicated IVF. When is it indicated for somebody maybe to try a natural cycle versus medicated?
So the standard in the United States and the recommended way to go with most IVF is medicated with a vigorous stimulation to get multiple eggs. When you look at many studies, most of the studies show that getting like a lot of eggs, that treating IVF like a numbers game seems to yield the highest pregnancy rates, because a lot of eggs and sperm are no good. And if we can get, the more eggs we can get, the better chance we have of getting a really good embryo. Mm-hmm. Now, some people, after repetitive tries and multiple different protocols, they just don't make extra eggs. And, if you always make only 1 or 2 eggs to $5,000 worth of drugs,
right,
and you make 1 or 2 eggs to $0 worth of drugs, then you might as well not spend the $5,000 worth of drugs. So that's
great explanation.
Typically when we recommend natural cycle IVF.
Right. Okay, that's a really good explanation. Okay, is an 8 millimeter follicle good size?
That is that's a pre-antral follicle, so it's very, very small. And, we don't know we don't know whether it's going to respond to medications or not. So that's super small. Usually once they reach 11 millimeters, then we know, it's starting to respond to drugs.
Got it. Okay, perfect. She went for a scan and they said it was looking good, so fingers crossed. It's just, Amy, it's so nice to come on here and have that extra reassurance, right? I think we all do that. Like, we hear it from our doctor and we're like, but are they just telling me what I want to hear, or is it really good? So I love these chats with Serena, because you get to hear like, yes, this is what they want to see. So it is good and you're heading in the right direction. So fingers crossed for you on that. And yes, good luck to everyone. Okay. Very last question, because we have to let Serena go, from Gladys Martinez. What does it mean when you ovulate with clomid and letrozole, but don't get pregnant?
So it means that that can be totally normal. Like the pregnancy with clomid and letrozole tends to go from around 10 to 25% per cycle, depending upon your exact situation. Like if you're PCO, it's higher. PCO and younger, it's higher. If you're unexplained and older, it tends to be lower. So a lot of people do not get pregnant with clomid, right, and we usually tell people try with clomid or letrozole and IUI 3 times. If you're not pregnant, then it might not be for you, and it might be time to think about IVF. So it doesn't mean there's anything wrong, and it doesn't mean you're not going to get pregnant. It just means, that didn't happen to be a good egg that month.
That's great. And Annette, we don't have time for any more questions, but I want to encourage you to hop on the Fertility Answers app to ask your question, because we have the inventor of genetic testing of embryos is the co-founder with me of my company, who can answer this concern about, does a PGS normal embryo trump the embryo grade? So please, Annette, ask that question on the Fertility Answers app. It is available for free on iOS and Android. We have so many great geneticists, embryologists, plus REIs who can answer that question for you. And I think that's a really important one that has
a long discussion.
It's a long discussion. That's why I'm encouraging you to go to the app, because it's a long discussion. So you'll get some very good, thorough answers. And then next Monday, we can bring it back up again based on what you did get answered and talk it through with Dr. Chen. Sydney Chick wants to know if she can private message you on your Instagram.
Sure. Yeah.
Okay. Awesome. So Sydney Chick, yes. So she's at Dr. Serena H. Chen.